Hello, welcome back to another episode of Ask the Doctor with Dr. Jeffrey Sherman. Today, we're going to be talking about how the political and legal landscape of medicine affects doctors and affects COVID care. As of today, July 30th, there are 4.4 million cases of COVID-19 in the United States and 150,000 deaths. Those numbers have been increasing a lot. As we've
4.4 million in the country, huh?
Yeah, in the country. That's very significant. It was only like 2 million, it was only 1 million not that long ago.
Yeah. And if we just do a quick calculation, 4.4 million, and then what was the 150,000 basically?
Yes.
So we're looking at a rate, a 3% fatality rate. That's not small.
That's not small. What's the fatality rate of I guess the flu?
It's like 0.5%, a half to one.
Yeah. So that's 6 times more deadly than the flu.
Right.
But of course, there's chronic conditions that we're discovering that COVID causes as well.
Yeah, so far, I mean, chronic is, you got to define that. We've had, 6 months of COVID, basically from January, February till now. So, or with really knowing about it since March, I guess, or knowing the cases. So, we'll see in 5 years what some of the post-infectious effects are. But I'm sure there's not any it's not going to be good.
Right.
So
Yeah.
gotta wait and see what happens.
In fact, is that the definition of chronic? 5 years?
Not necessarily 5. I'm just saying it's more than 6 months, though.
Right. Yeah.
So it's all relative. It's over amount of time. But chronic, but 5 years would qualify as chronic, in my opinion. If you were to have some kind of symptom or condition that you picked up in 20 and you still have it in 2025, I did chronic, and you picked it up because you were positive for COVID, I would qualify that as a chronic post effect
Exactly.
or after or side effect.
I know that the disease seems to cause permanent lung damage in people. Can the lung repair itself over time?
It can, and then you'll have some scar tissue there.
Okay.
But it can repair itself, and you can certainly function fine and be mostly the same person. It may take its toll when you exercise or going uphill on a walk or go or travel to higher altitudes. You may notice you don't have your wind. You can get a little short of breath quicker than you once did. That doesn't mean you can't do what you want to do. It just may mean you're a little more short of breath from scar tissue or some breakdown of some lung exchange, gas exchange tissue. So that's, you may see something like that. You may not, if you're a trumpet player, you may not be able to play it at the same level as you did because you don't have the air capacity, but, things like that. But, baseline, and depends on the patient, but those are the things that you may notice changing in the long haul.
Okay. And scar tissue, what exactly is scar tissue?
It's the transformation of the actual tissue. It could manifest itself as thicker, hardened material. It's just or cellophane, like cobwebby stuff around the lung. Things that just restrict the ability for the organ, or in this case the lung, to function. Just residue material that won't let the lung expand as much or will interfere with the gas exchange.
Okay.
There we go.
All right, I see. So scar tissue is kind of like, well, it's a scar in the sense like you can get a scar on the surface of your skin, right? Um it's a leftover, I guess, of trauma to the tissue.
Right. Trauma, infection, inflammation.
Okay.
Um, yeah. Uh, or just manipulation of the area. It's leftover residue. It's not the material, whatever it may be, is not infectious or damaging, but I mean, it's just the effect on the vital organ is the difference
I see,
it
I see.
has.
So, um about the, I guess, the political and legal landscape of medicine and doctors and COVID is, I'm sure there's some people out there who don't, even I don't quite understand how the legality works in medicine. So sometimes we might wonder, like, why can't we just do this now? Why can't we just do this? Well, it turns out, I believe there's certain legal proceedings that have to happen before things. Is that correct?
Yeah, I mean, you things. Um, you want good outcomes. You can legally, I guess, you can legally do anything. It's not against the law. There's no laws on the books of the state or the country that
Okay.
govern regulations, and drugs go through approval processes. Doctors have to be licensed and things like that. But there's no laws that saying you have to, if you prescribe this medicine in the wrong scenario, you're going to be arrested. But you got to do within the regulations as put forth by each state or the federal government, the country. Doctors make their recommendations based on their own uh, knowledge, their own experience, and data they know. They're not going to
Okay.
give medicine X unless it's indicated for disease X. They're not going to give it willy nilly. The legal aspect comes when doctors are negligent and will get sued for things that they do wrong. So legal stuff is more civil as
I
opposed
see. Okay.
to how do procedures and as I was saying, there are some you know criminal proceedings when it comes to doctors if they're doing fraudulent
Right. In the extreme
practices,
cases.
things like that. Um, but in terms of you know, you treat a patient as best you can, and if there's a bad outcome, God forbid, the patient does have some legal recourse in terms of malpractice and negligence and things like that.
Right. But sometimes that can be overused because things in medicine can kind of just happen. Like some
Right.
like there's always chances for basically anything to happen when it comes to medicine, especially in surgery. Surgery is very serious.
Right. And that's why before surgery, before a procedure, the doctor will explain to the patient the procedure and what to expect afterwards and what can go wrong during. Very uncommon, but they have to be the patient has to be informed of what can happen. Then the patient will sign the consent saying they understand the risks of the procedure, they understand the procedure and what's going to happen, and they sign away that they understand, and then the procedure goes on. However, if something unforeseen happens during that procedure that is outside the scope of that consent, then the patient has
Okay.
some some uh, some legal ground to do something if they wish, depending on what happens. If a complication happens within the scope of that consent, it basically covers the legal aspect of it. However, that may not stop a patient from pursuing, the doctor, in that case. It's a complication. If it's a complication that is clearly outlined in the consent, usually the patient has no legal ground.
I see. I see. Okay. So it sounds like this consent form has to be very detailed, as detailed as possible, um, for the doctor's sake,
Yeah,
basically, and for the
consent
patient.
form. Yeah, there's a lot of fine print. There's a lot of fine print there. Some patients read it all. To be honest, most patients sign the consent after the doctor has verbally explained things and answered all the patient's questions verbally. But there is a lot of fine print on those consents, and some do sit there for halves of hours or hours reading it, and it can hold up surgery schedules. To be
Oh,
honest with you, but if they have the right to read it, that's certainly okay.
yep. So let's see. And on the subject of, I guess, medicines and prescriptions, I know that there's been talk about various different COVID treatments, one of them being hydroxychloroquine,
Yeah.
and I'm certain there's others. But what's the regular process by which, I guess, a drug becomes usable?
Yeah, good question. That's it's a lengthy process generally because you need patients and subjects. So you go with what they call a randomized control trial, preferably a double-blind randomized control trial. You take patients with COVID, similar symptoms. You know, you want to include a group of patients between 18 and 55 who are, you know, have COVID in the community. Once a patient's been, tested positive, they can be in the study for hydroxychloroquine. I'm just saying how this works. And You would give uh, a little pill. You pick the patient. Okay, the patient. Here comes the patient. He's got COVID. Pick a group: the hydroxychloroquine group or the control group. The hydroxychloroquine group will get the hydroxychloroquine, and the control will get like a sugar pill, a placebo. And you say, okay, you're going to take this number of milligrams for 10 days, and then we're going to see how you feel, take your pulse ox, retest you every 2 days, and see when you turn negative. And we'll take the control guy, and we'll test those guys. Now, it's great if the patient doesn't know which medicine he gets, and it's great when the doctor doesn't know which medicine he gets. That eliminates bias, right? So you get two different groups going forward. Doctor doesn't know what medicine patient A gets, and the doctor doesn't know what medicine patient B gets, and you compare the two groups. Now, you'll have to reveal what the medicine is at the end of it, but the doctor doesn't know and the patient doesn't know. And you got to measure things. So you watch to see if there's a benefit from hydroxychloroquine. Did the 400 hydroxychloroquine patients do better than the 400 placebo patients? And that could take several months. So we were still doing this trial, and it's taken several months. And you look at the numbers and go, well, the hydroxychloroquine patients cleared the virus in 12 days, and the placebo group cleared the virus in 13 and a half days.
These are arbitrary numbers.
Okay, is that something? Is that something? You know, there's formulas to determine how accurate all that is. At the same time, you got to look into side effects and adverse effects, diarrhea, abdominal pain, just whatever the patient would bring up. And that can take some time too. So in order to get all this, so you got to have the medicine tested up against nothing and then see if there's a benefit. And if there is, and after everything checks out, you present that to the FDA and you present that in the medical journals, and they approve the medicine, and it gets on and it gets out released to the pharmacies and you can use it. But until all that process is played out, you can't legally
Right.
prescribe that medicine, or you can't in confidence prescribe that medicine for that problem. Um, if you like the way the data looks, you could do it or prematurely, or if it's still not FDA approved, you could do it, but you got to tell the patient it's not FDA approved, but we're going to do it anyway. So my point
Okay.
is, you started at the beginning. Some patients get one, some patients don't, and you compare what the outcomes are. And if that looks good, then you present it to the FDA and they'll approve it. If there's no benefit, then that's the end of the road.
I see. So,
That's how vaccines get approved as well.
that's right. Yeah. In fact, is that basically how like all medical treatments get approved?
Right. There has to show an efficacy, and it has to show a good safety. No major trouble. The second patients start having trouble on a medication, the study gets pulled.
I see. Okay.
Patient having the medicine started having a lot of EKG changes in their heart. Well, that's not
Oh,
going to be
okay. Yeah, yeah,
tolerated.
that's bad.
So then, boom, done. Start over and think of another medication. But if there's no if there's no major trouble, a side effect of headache or diarrhea, they'll in 2 to 3% of the people, no problem. But if you have some other coinciding other medical problems, then the study gets pulled and the good.
I see. So, I remember how you said earlier that are doctors kind of allowed to give their patients something that's not FDA approved as long as they disclose that it's not FDA approved?
Yes,
Oh,
they would give a medicine that's FDA approved, but not necessarily for the reason it's FDA approved. We call that
okay.
off-label. So it's legal to do that. You can, and it's morally okay too, because you've seen other data that looks promising. It's just not officially FDA approved, and in your own experience, you've seen outcomes that have been favorable. But uh, you know, that's I mean, hydroxychloroquine's it's a good example. Hydroxychloroquine is an FDA approved drug. Okay, it is
Okay.
FDA approved for rheumatoid arthritis, and many patients take hydroxychloroquine for rheumatoid arthritis and do fine on it. But the off-label use is for COVID, so you can say, "Hey, I hear it's pretty good. Why don't you take this FDA approved drug for rheumatoid arthritis for COVID, which it is not FDA approved for?" So that's a use of the off-label um, technique of hydroxychloroquine. They're trying to get it FDA approved for COVID. Doesn't look like it's getting very far, but you can still prescribe it for it because it is an FDA approved
I see.
medication that went through the trials years ago for rheumatoid arthritis.
So it seems like even if a medicine goes through trials that deem that it's at least safe to use,
Right.
then somebody is allowed to use it even for a different condition as long as the doctor thinks it's okay.
Yes, but remember the safety profile. You have to read the studies of the drug and to see which patients it was studied on to extrapolate that to your current case. What I think was going on early on, they were given hydroxychloroquine to some of the ICU patients or hospitalized patients, and hydroxychloroquine was not tested on those patients in the rheumatoid arthritis trials because those patients were not that sick. So we weren't seeing the side effects in the rheumatoid arthritis patients that we might have been seeing in the hospitalized ICU patients. They were trying on it for the COVID. You see what I'm saying? The
Okay,
patient population is a little bit different there. The
I
drug,
see.
so you got to compare apples to apples in terms of patient population. So in order to be really safe, so that's why originally I said, well, let's do it on the outpatient COVID patients who who are not in the hospital and see if that helps them because they may be the same patients for the rheumatoid arthritis. But if you're testing it on sick ICU patients, we don't know what hydroxychloroquine will do on them because those are not the rheumatoid arthritis patients that went through the trials originally back when.
I
So you
see.
got to think about that.
Um, so I guess it's just like how you can't test a drug's effects on only one age group. And just like how you can't test I mean, you can test a drug on just one age group, but if in order to prescribe it to a different age group, you have to do data on those age groups. And I guess
Right,
that's the same with
and
the
they break it
ICU.
down. These trials break down the demographics of the study population to show you, how many of each age group is enrolled and what side effects or complications were met within each age group, and so on. It's all in the study. It just takes, it's boring reading, to be honest with you. You're looking at a lot of numbers and stuff. You just want to, you know, cut to the chase. But they do report that, and that's important to note when reviewing literature and knowing what drugs work for what age groups and what types of patients.
Right. Okay, I see. Let's see. We do have a question from the chat about why if one single virus can replicate itself in a cell and no one has immunity to COVID, why does the quantity of virus taken in affect one's chances of infection?
I just think it's a law of numbers. That not every virus gets to the host area that you know um, affects the patient. I mean, it's just the more virus, the more chance it has of latching on to that particular receptor in the
Right.
lung that will cause the whole cascade of you know disease. It's just like if a male's sperm count is high, more get a chance to get to the fertilization point than if he has fewer. Same thing. If you get more virus into the nose, more will get to the lung, more of a chance to get to the lung than if fewer were inhaled. Because just in the nose doesn't automatically mean you're going to have symptoms and be in trouble. It's got to get down into the back of the throat and spread like a fire down to the lung. And the more that seeds the nose, the more has a chance that seeds the
I see.
connecting tissues there. So it's kind of like just a law of the numbers. And
It's
masks can
because
prevent multiple viruses from, can cut down the numbers.
exactly. And I guess it's how the body has defense mechanisms against everyday viruses and bacteria because of things
Yeah.
like the nose and mucus. They just capture pathogens before they even enter your body.
Right. Right. And
And
the
it's things like that.
and the little what they call vibrissae, or the little nasal hairs, are act as barriers too. Those serve a function and trap viruses and particles and protect your nasopharyngeal airway area and help against viruses and bacteria.
Um, so on about the COVID treatments, I remember there being a malaria drug, but was that hydroxychloroquine or
Yeah,
was that
that's
something else?
hydroxychloroquine. It's also for
Oh, I see.
malaria. It's for rheumatoid arthritis. Yeah, it's the same one.
Oh, wow, that's cool. I imagine
Yeah.
hydroxychloroquine being on the spotlight is because because you told me how it treats rheumatoid arthritis, and I guess that means it somehow treats inflammation, right?
Right. right, and it works on immune systems too. It treats inflammation and it works on the patient's immune system, thinking that the sick patients in the hospital were uh, were the viral storm, the cytokine storm. It can help kind of prevent that. It was thought to be that was why it was thought because it has that autoimmune anti-inflammatory property that is helpful in rheumatoid arthritis patients. Yes.
So now I would like to bring up the subject of things like vitamins, supplements, sometimes what might be considered herbal, whatever.
Mm-hmm.
Um, how, well, I guess what's a doctor's relationship to those kind of things?
There's naturalist doctors out there who believe in it wholeheartedly, and I don't necessarily disagree with them. I just go with traditional medications. I don't. I sometimes suggest a couple of alternative, herbal or supplemental medications in the setting that the traditional prescription medications are falling short or not working. Um, and most of the time, a patient would bring up, "Hey, can I? What do you think of supplement X, or what do you think of this over-the-counter supplement?" And if it's the right one in that setting, I would say feel free to use it. I'm not against it. Um, so it depends on the doctor. Some poo-poo those things, and others have open minds. And then some doctors base their whole practice on prescribing them. But I
Right.
think there's a role for those in general in the certain medical setting. For example, if a patient is not having any with bad acid reflux, is not having any luck with the traditional antacid medications, I'm like, okay, well, maybe you can try this over-the-counter supplement, aloe vera juice or ginger root supplements or uh, uh, apple cider vinegar, and those can help with the symptoms in the setting of traditional medications not working. If a patient prefers to take those first, I'll agree to that, but I will let the patient know that it may or may not work. But all doctor dependent. But there are certain supplements out there for various particular conditions.
Now, is a dietitian a type of doctor that specializes in like the food that the diet that someone has?
So a registered dietitian is not a medical doctor. He or
Oh, it's
she
the
is
other one, nutritionist?
just a dietitian or a nutritionist. They have a
Oh,
different
okay, do the same
degree.
thing.
Okay, they have a
Oh,
different
okay.
degree. It's an actual dietitian's degree, which is great, um, because doctors are happy. GI docs are happy to discuss certain dietary modifications, but when you need big time details and want to spend real time on it and the mechanism of the certain foods, you can visit a dietitian and get a real good breakdown of what to do and don't do in certain disease conditions or certain
Right.
GI conditions and so on. So but that dietitian is not a doctor, cannot prescribe medication, just advise you on foods.
I see. Okay, so there's a little bit of a difference there.
Supplements too, and supplements. They'd be a good source for information on the supplements we were just talking about.
Okay. Yeah, that's good because like um supplements are they're obviously not medicine in the sense that they're uh basically derived from food. They're derived from things that you can eat and be fine.
Right,
And
right,
medications,
and their standard is low. They don't have the FDA approval, so it's buyer beware. Take at your own risk. You might, who knows what kind of side effects you'll have with these. They're not drugs that are going to alter the body. They're supplements that you either absorb or don't, but there are still some side effects from them:
yeah.
diarrhea, headache, sleeplessness, nausea, whatever the case may be. They're still out there.
Is there Before we start slowing down the show, is there anything that you wanted to bring up about this subject?
Um, yeah, I just wanted to, as patient, I just urge the patients to be informed, to ask good questions, uh, and to understand. The have an understanding between your physician and yourself, the course of action. So there's really no surprises or told you so's or gotcha moments down the road that results in some legal issues. As we wanted to talk about legal stuff this show,
Right.
I just want the patients to understand and that you and the doctor are a team together, and there's no stupid question to be asked. It's all very good, and between you and the doctor, you'll get the patient improved and better, and hopefully without any hiccups or side effects along the way.
Exactly right. That's important. There needs to, I guess, be more of a really more of a friendly attitude with doctors and patients because a doctor is just there trying to help. That's their job. That's why doctors became doctors generally.
Yeah,
And it's important that the patient uh, helps the doctor and the doctor helps them.
right. The patient, right. I look at it as a doctor and the patient. The doctor didn't go out there and drag the patient into his or her office. The doctor, patients voluntarily sought medical attention, and then the doctor helped the patient to the best ability.
Exactly. And right before we end off our show for today, we would like to remind people to wear their masks, wash their hands or use hand sanitizer, um, and of course, use social distance and generally do all the things that we've been trying to get people to do to slow down the pandemic. It's very important. We do not want the intensive care units and the ventilators to be uh, out of supply because that results in many more casualties than there needs to be. If you want to,
Right.
if you're in the LA area and you would like to see Dr. Sherman for an appointment, you can email Dr. or sorry, you can email his email, which is towergastro@gmail.com to sign up for an appointment. And we do ask the doctor every Thursday at 3 p.m. So until next week,